We are here to start with the second program, the clinical examination of spine.
No, we can start, sir. We can start.
I already started, sir. We can start today's second class by Professor Nalli Uvaraj on the clinical examination of spine. We welcome our TNOA President, Professor Thirumalaisamy, Dr. Saravanan, PT Saravanan, who are the backbone of teaching program, especially in this lockdown period, which is essential for the postgraduate teaching. I welcome our coordinators, Professor Danapan, Professor Thirunarayanan for the session, and also welcome our advisors, Professor Chengalpattu, as well as Professor Vettivel Chelian. I welcome our moderator, Dr. Ramprasath, to moderate the session. Now we will go ahead with the program, introduction of the moderator by Dr. Professor Thirunarayanan.
Thanks, Suresh sir. So it's a very pleasant evening today. Thank you so much for allowing me to introduce my very close friend, Dr. Ramprasath. So my association with Ramprasath is a very long time, and now he is associate professor in Government Chengalpattu Medical College. So he is, two schools of thing. One is from Madurai and from Madras. So he's done his D-Ortho in Madurai Medical College. So he's a combination of both Madurai and Madras. So he's done his MS Ortho in Madras Medical College. Very fine teacher. So he's he's very strong in basics. So he can speak in any aspect of orthopedics. So that is his strength actually. And also his concepts will be very clear. He will not have any ambiguity in his subject. So and also his surgery also he can perform any type of surgeries. So that has been his basic strength because he's done his D-Ortho and MS Ortho. And all he's learned is very, very strong in his basics and also surgical skills. So I take the pleasure of introducing Dr. Ramprasath. And Dr. Ramprasath, over to you.
Thank you, Dhiru. Thank you for your compliments. And through is exactly a mirror image of what he had explained out about me, actually. So thank you, Dhiru. In this testing time of COVID-19 period, it's really difficult for the PGs to adapt themselves to the situation. And the exams around the corner at any time, they are really struggling to find out the way how to familiarize themselves with clinical examination in orthopedics. And the TNOA has rightly and promptly come out with this idea of a TNOA teaching program, which will be immensely helpful to the PGs who are going to attend the exam this year as well as next year. Because already the final year PGs have lost the considerable amount of duration of their PG time in this COVID time. So for the final year PGs who have entered in and the exam going PGs, this session will be definitely useful. And spine is considered to be a difficult case in MS Ortho examination, but in reality it is not true. Actually, it is actually better to get a spine case than to get a bilateral hip case. Myself also was thinking during my exams that spine is a difficult one, but I received a spine case and easily swam through that. So spine, if you properly examine and present, it's going to be an easy way through for all the PGs. And to present this clinical examination of spine, we are having Professor Nalli Uvaraj. I think we cannot get a better person than him, who has got a vast teaching knowledge. He is the teacher of teachers, and he is the teacher of myself also. So Nalli Uvaraj sir, he is exemplary in this particular aspect of teaching, particularly the spine. So I request Professor Nalli Uvaraj to take over and start his presentation. So the PGs can send their questions or doubts in the chat box, which I will reflect later. Over to Nalli Uvaraj sir.
Yes. Thank you, Dr. Ramprasath, for the nice words. At the outset, I would like the Tamilnadu Orthopaedic Association, its president, Dr. Thirumalaisamy, who is here on the occasion, Dr. P Saravanan, the secretary, for giving me this opportunity. And they have chosen two senior people who are good at organizing academic programs, the advisors, Dr. Chengalpattu and Dr. Vettivel Chelian, and ably assisted by the coordinators, Danapan, Suresh, and Dr. Thirunarayanan. I think this is one program, the teaching program for the postgraduates made essential during this period of COVID crisis, because a recently held survey which we had conducted in Madras Medical College, all the residents are highlighted that this is one feature which is really bothering them: the lack of training, and the how much they miss the teaching programs. I would not say that we are going to fully bridge the gap by conducting these webinars, but we will make an effort. To some extent, we can bridge the gap. And I only request all the postgraduates to utilize this time in picking as much as possible the good points during all these lectures, and use them during the examinations and come out with flying colors. I must say that this program is going to be on the YouTube. I only request our postgraduates not to keep writing. They need not jot down anything, because it's going to be there, and they let them just listen. You just listen, absorb everything, whatever we are going to say. I think that will be more useful to you. As Dr. Ramprasath said in the beginning, I think there cannot be a confession as good as that of Dr. Ramprasath, who himself had a spine case. Generally, everyone thinks that spine is very difficult. It is not really so. It's something like a mathematics. Okay, it's 1 + 1 has to be 2 only. So it's just a mathematics. If you're going to put everything, all the puzzles into jumbled puzzles together, if you're going to solve it, you're going to get the answer. So try to listen to this lecture and try to pick up as many points as possible, so that I'm sure this lecture is going to be useful for that. So let me start sharing my screen now.
Sir, Nalli sir, can we have your video, sir? If you don't mind. Video is there, sir.
Really?
Yes, sir. You're not able to see your video.
It's dark. Okay. 1 minute.
Yes.
No, we are able to see. I am able to see Nalli Uvaraj sir's video.
I was also able to see.
We are able to see you, sir. We are
No, sir, Nalli sir, you can continue, sir. We are able to see your video. The only thing is that at the time when 2 speakers are there, only the name flashes.
Okay, fine. I will just share it now. Yeah. Spine history and physical examination, the tips and tricks. So the components of this lecture are going to be the history taking, then the components of the examination proper, that's the inspection, palpation, movements, measurements, and neurological examinations. Now, more mistakes are made from want of proper examination than from any other reason. And the ability to gather the appropriate information from the history and the physical examination forms the foundation of a well-constructed and effective therapeutic regimen. I think this is highly true. And though there are technical advances in the form of modern imaging, still a complete and accurate history, a skill that has to be mastered by each and everyone, leads to a set of differential diagnoses. And based upon these differential diagnoses, appropriate physical examination and radiographic evaluation has been taken forward. But nowadays, what we see the other way. People just start seeing the X-rays and the scans and then go back to the examination. I think this should not be there. It should be the first history, then the examination, and then the imaging. Yeah. So patients with spinal disorders commonly complain with the following 3 complaints. One is the pain, deformity, and neurological deficit. Neurological deficit, they're not going to say that I'm having a deficit. They might come with symptoms like numbness of the limbs, they feel heaviness of the limbs, or difficulty in walking or unsteadiness. So these are the features which they might come out with in the history. Now, pain, as far as pain is concerned, you got to consider them in these headings: the site, radiation, quality, chronicity, severity, aggravating and alleviating factors, as in any other pain description. Now, coming to the site of pain, most often the pain is located in the axial region. It can be the cervical, thoracic, lumbar, lumbosacral, or the sacrum, based upon the region which is involved. But other regions which can be involved are the paralumbar region, interscapular region. Interscapular region, like pain in the cervical spine, pain due to cervical spine pathologies can present as pain in the interscapular region. A lot of times we've seen that once the patient complains of interscapular pain, the doctors start taking X-ray of the thoracic spine. So it is not so. But first of all, whenever patient comes with the interscapular pain, you should ask whether they have a pain in the neck. And also the pain can be located in the gluteal region, and it can also radiate onto the lower limbs or the upper limbs. But these are the typical locations as far as spine pain due to spine ailments. But you should always remember the referred pain can also be due to viscerogenic causes. Like as you can see in the diagrams here, the one here, this region, the shoulder region, can be due to cardiac ischemia, or any cholelithia, the gallbladder problems can present here. So you should also always keep in mind the viscerogenic cause for the pain, which can present as referred pain. But the dermatomal pattern of distribution of pain should be looked for, otherwise known as the radicular pain. Now, the pain in spine disorders can be a referred pain or radicular pain. The referred pain commonly arises from the disc and the facet joints, and they are less discrete, poorly localized, and worsens over the course of a day. Whereas the radicular pain, which is due to involvement of the roots, are deep aching and shooting, has a specific distribution, what I call as dermatomal distribution, and worsens by maneuvers that increase the intrathecal pressure. And referred pain is not accompanied by neurological signs and symptoms, whereas the radicular pain is accompanied by neurological signs and symptoms. Now, coming to severity of pain, data may be obtained regarding the disability imposed by the pain, whether pain is present only with physical demanding activities or pain occurs with activities of daily living. Coming to aggravating and alleviating factors, pain due to mechanical dysfunction of spine is aggravated by general or specific activities and relieved by rest. This is what we call mechanical pain. And this helps in differentiating pain due to other extraspinal causes like probably viscerogenic pains. Herniated lumbar disc pain is aggravated by sitting and bending forwards because of the increased intradiscal pressure. And similarly, lumbar facet syndrome or spondylolysis, here the pain is aggravated by standing or extension of the spine. Metabolic, infectious, and malignant disorders may also initially present as axis-related pain. Constant, unremitting pain not impacted by physical activity, or pain which is bothersome at night and at rest, the rest pain or night pain, if they are going to present, they are indicative of tumors or infection. Now we will be dealing about specific conditions now. Normally, the dimensions of the lumbar canal and the neural foramen are increased when the spine is in flexion. And whenever in conditions like spinal stenosis in the lumbar region, the effect of increased lumbar lordosis, like when they are standing or walking, leads on to posterior disc compression and bulging into the canal, with facetal overriding and buckling of the ligament flavum, all this leading to further encroachment upon the central canal and neural foramen, which is already narrowed by the hypertrophic facets and degenerative discs. So that's the reason why you can see in the diagram here, in flexion, you can see the the dimensions of the neural foramen here, whereas here it is narrowed here. So this is the principle behind the relieving of symptoms in spinal stenosis by bending forwards. Now, pain in the lower extremities, which are accentuated with ambulation, are known as a claudicatory pain. And you got to differentiate the neurogenic claudication present in spine-related problems with that of the vascular claudication. The neurogenic claudication is relieved by sitting or bending or leaning forwards. That is, whenever the flexion attitude of the spine is maintained. Whereas in vascular claudication, just by stopping, walking, or standing, the pain gets relieved. And in neurogenic claudication, walking uphill when the spine is held in flexion is painless, but whereas downhill when the spine is extension is painful. And bicycle, when driving the bicycle, when they have a flexed attitude, it is painless. Similarly, in vascular claudication, walking uphill is painful, whereas walking downhill is easier, so it's painless. And bicycle test is again painful because you're going to strain. And the walking distance is very important, very, very important. In vascular claudication, it is constant. Say, for example, if it's going to 50 degrees, you get the 56 meters, you get the pain, you'll definitely get it in the next episode also. Whereas in neurogenic claudication, the walking distance variable with each episode. At one time, you may be able to walk 100 meters, like, next time it will be 75 meters, then next instance maybe 200 meters, like it's grossly variable. And then in the neurogenic claudication, it begins proximally and progresses distally, whereas in vascular claudication, it begins in the calves and works up proximally. Now, going into the specific condition of cervical myelopathy, It is characterized by absence of marked pain and often leads to a lengthy delay in the diagnosis. See, whenever there's a pain, immediately you pay attention to it. Whereas here, you do not have a pain at all, or you have a very vague or mild pain. And the neurological symptoms are also less well-defined. Hence, there's a delay in the diagnosis of this condition. So you should have a high index of suspicion when you have all these features. Like it can present with a numbness in the hands, or feeling of clumsiness or weakness in the hands, what you call a poor hand dexterity. So you can ask them to button their shirt and unbutton their shirt. So they will not be able to do that. As for lower extremity is concerned, there may be a sense of imbalance or difficulty in ambulation or feeling of global weakness in advanced cases. And sometimes it can also present with urinary frequency and urgency, or even urinary and fecal incontinence if it's going to be a very florid case. Now, the spinal stenosis can present with lumbar spinal canal stenosis, presents with pain in the buttocks or legs or both, which will be diffuse and vague. And the numbness and paresthesia may be in the legs, and they may also present with altered bowel and bladder function in severe stenosis. I think you must be aware of the Cauda-Econo syndrome, characteristics of it. There is a bladder and bowel dysfunction with saddle anesthesia and variable loss of motor and sensory function of the lower extremities. Now, the second complaints, after the pain, the second most common complaint is the spinal deformity. So you got to know the duration since when it is there, whether it is from birth or started recently. Any recent change in the fitting of the clothes or change size of the clothing, which may indicate a progression of the deformity, a loss of height. You might see it in osteoporosis or in spondylolisthesis. There may be loss of height as the condition progresses. And also you should give due consideration to the emotional and the psychological impact of a marked cosmetic deformity, how much it is affecting the individual. It's very, very important. A good medical history is also very, very important in all cases. Like the presence of fever, malaise, or weight loss, you should suspect a spinal infection or tumors. And viscerogenic cause for pain, the viscerogenic pain we call it, has to be always kept in mind. As I showed in the previous slides, it may be referred to the various regions on thoracic and the lumbar regions. Psychiatric illness, particularly depression, clearly play an important role in the approach to treatment. First of all, the depression can present with it can affect the presentation by itself, and it also can affect the treatment aspects. Social history is very, very important. You should probe the type of work the patient is involved in patients with spinal ailments, because a certain type of works are prone for certain disorders. So you got to counsel them on changing the type of work. So hence the social history may be very useful. Use of alcohol and tobacco abuse, all these has to be taken into consideration. And due consideration should be given to is there any involvement of secondary gain issues? Are they going malingering it? Maybe to get certain concessions, they might be malingering. So you should take into consideration are there any secondary gain issues? A family history is very important. There may be a strong family association with adolescent idiopathic scoliosis, and this allows for proper counseling of other family members. And history should also probe into the comorbidities. What are the because for a surgery, you might have to consider all these things, whether he's taking any medications, or are there any allergies. You might be taking a blood thinners when you might have to stop it for some time. You're going to take it up for surgery. And most important is the previous treatment. A good exploration into the previous year, what all treatment is undergone is very, very important, because you should not be repeating the entire treatment again. And finally, by the end of history taking, we should have a firm diagnosis or a differential diagnosis. And based upon this, you got to go into the clinical examination and the investigations. Now we'll go to this is as far as the history is concerned. Now we'll go to the clinical examination. I am going to deal with it specifically for cervical spine, and then the thoracic and the lumbar spine separately. Now, before starting examination, you should ask permission to perform examination and explain the patient appropriately what all you're going to do in your examination, what you expect from the patient, and tell the patient to let you know if anything that you do is uncomfortable or painful. When female patients there, make sure that a female nurse or assistant is present. Now, gait. You start with the gait. This is the first step of examination, and ensure that the patient has reasonable power in the lower limbs to assess the gait, and provide assistance if needed. And if there is any impending neuroid if the patient is not able to walk, then assessment of the gait should be absolutely avoided. So we will go into the various types of gaits. One is the commonly encountered one is the myelopathic gait, which is wide based. This is the one here. the myelopathic gait, which is wide-based, clumsy and staggering or ataxic, and it's unsteady, and they might even require support to ambulate. And these are very common in thoracic and the cervical spine pathologies. See, wide base there, it is spastic and ataxic also, and these supports also. Tandem walking, this elicits subtle signs of imbalance or lack of coordination as it's found in myelopathy and also cerebellar disorders.
The tandem gait exam is evaluating for cerebellar and proprioceptive problems. I'm going to have you walk heel to toe about 4 or 5 steps. Okay, now stop. Come right back and start over again. We're going to do it with your eyes closed. Good.
So this is how you do the tandem walking, and this elicits subtle signs of imbalance or lack of coordination. Now, Trendelenburg's gait. People think that Trendelenburg's gait is just to deal with the hip alone. No, it is also to be found in spine disorders. And it is due to weakness of the gluteal muscles, like which is supplied by the L5 muscle, and it produces a proximal myopathy. So this is one case of a Trendelenburg's gait. This is a person with a massive disc affecting the L5 supply on both sides, and he had a Trendelenburg's gait like this. And this patient after surgery improved, recovered fully. He had I was not able to trace that video. I could have shown you the normal gait he had after surgery. And this is the high stepping gait due to loss of the dorsiflexion of the ankle when the L5 root is involved. And it may be associated with L5 dermatome sensory loss. And antalgic gait, like where the short stance phase, is found in any condition that cause pain in a lower extremity or referred pain such as sciatica, and this can produce an antalgic gait. Now, coming to the examination proper, the patient should change into an appropriate gown or other cover. Like, for example, the boys can leave off the hospital gown and the girls can have the back of the gown moved aside for proper examination, but most important, while maintaining modesty. At the same time, during the evaluation, however, the chest should be examined. So as I told you, I'm going to start with cervical spine. Now, starting with inspection, you got to have a look at the head position, whether there's a head tilt there. And the patient is seated and the neck is viewed from the front, sides, and the back. And the presence of torticollis may be due to muscular causes like inflammation of sternum mastoid or traumatic injury, or other conditions like cerebellar dysfunction, congenital scoliosis, or atlantic instability, and ophthalmologic disorders. Very important. You got to also remember that also. Here is one case where it's tuberculosis of the C1, C2 region with destruction of the lateral mass on one side, which present with torticollis. And you should also look for whether there's a neck shortness or the presence of a low hairline, which indicative of a congenital disorder, congenital scoliosis. Now, so you go to, it's coming to palpation, you got to palpate all the spinous processes, and these spinous processes correspond to important anatomical landmarks. Like, for example, the C3 level corresponds to the hyoid bone, which can be palpated anteriorly just below the mandible, and C4 and 5 level with the thyroid cartilage, and C6 level with the arch of the cricoid cartilage. Now, on palpation, if there's tenderness of the spinous process or the interspinous ligaments, it may indicate a fracture or acute ligamental injury. A shift in the spinous process alignment may be an indication of a unilateral facet dislocation or spinous process fracture. And a prominent C2 spinous process, it should make you suspect an atlantoaxial subluxation. Now, tenderness of the trapezius or the medial border of the scapula should make you suspect a cervical disc herniation or facet arthrosis. Very commonly, you'll see this. You can palpate the trapezius and you can feel the tenderness there. Very common in cervical disc problems. And as I told you, it can also radiate to the interscapular region. That's what we mean by the medial border of the scapula. Now, coming to the movements of cervical spine, you got to look for the flexion, extension, and the side bending and the rotatory movements. Flexion is you'll be able to reach up, the chin can touch the chest wall, and extension can be, normally they say around 4 finger breadths from the back, the occipital region, and the distance between the occiput and the back would be around 4 finger breadths. And then they can flex, lateral flexion can be down, and rotation can be around 80 to 90 degrees. Lateral flexion is around 45 degrees. And you should remember that 50% of the flexion and the extension occurs at the occiput C1 articulation, and 50% rotation occurs in the C1, C2 motion segment. The rest of the movements occurs in the subaxial region. Limited extension may be an indication of cervical spondylosis, and limited flexion in case of muscular ligamentous injury or myofascial syndrome. So why do you want to have a recording of the range of movement? Because this may be helpful in monitoring the response to treatment. Now coming to neurological evaluation, a careful neurologic examination of the upper extremities is an essential part of the physical examination of cervical spine. And the nerve roots of the cervical spine exhibit, you should remember this, the nerve roots of the cervical spine exit above the pedicle of the corresponding numbered vertebrae until first thoracic level. For example, if it's going to be C6 vertebrae, the root is just above the pedicle of that, means C6. Characteristic sensory and motor and reflex activity, each root level is assessed. And the manual motor testing, the muscle grading is done by the medical MRC grading. I'm not going into details about them. The sensory examination should test for the loss of light touch or pinprick sensation in each cervical and the upper thoracic dermatomes. And the proprioception testing at the level of the thumb, and vibration sensation should be tested at the distal radius, head of the ulna, medial, and lateral epicondyles. And the testing of the proprioception and the vibrative sensation may be helpful when a neuropathy or posterior column disorder is suspected. I think I'm not going to detail because these are the things which I'm sure you must be knowing all of these. Then continuing with the physical examination spine, we need not examine the individual muscles like the neurologists do an examination of the individual muscles. Rather, it's enough that you examine the principal muscles of each dermatome, each myotome, and then you can come to a conclusion on the level of involvement. We will start with the C3 level. There is no motor weakness, no reflex changes, and the pain radiates to the back of the neck and towards the mastoid process of the pin of the ear. C4 level, again, there is no motor weakness, no reflex changes, and the pain radiates to the back of the neck and superior aspect of the scapula. Now, at this moment, we should know how useful is scapulohumeral reflex. What is the importance of scapulohumeral reflex? If you see, like any lesions affecting the spinal cord below the C5, they have specific reflexes and findings also, motor findings, sensory findings, everything. So very clear there. The region between and anything above the foramen magnum also has findings which can clearly pinpoint the level of the lesion. Whereas between C1 and C4, there are no objective findings which can define the lesion is there. So the scapulohumeral reflex is very useful in locating the lesion there. So this is done by this method here. If the scapula elevates or the humerus abducts, it is termed as hyperactive reflex, suggesting upper motor and neuron dysfunction above the C4 cord level. So this is done here. You just tap it over the tip of the spinous process or acromion. So you have the upward movement of scapula or the abduction of the humerus. You can see, just note it there. There, yeah. So this is useful in locating pinpointing the lesion between C1 to C4 levels. Now C5, I'll just rush through these because these are available in the books. So C5 predominantly you test for the deltoids, and the sensation is over the what you call Regiment batch sign, they call it. It's over the shoulder, the outer aspect of the arm, and the reflex is the biceps reflex, C5-6. I think all these you must be knowing. C6, the main motor is the biceps, and also the wrist extensors, biceps and the wrist extensors, and sensations of the outer aspect of the forearm, and reflex is the brachioradialis. C7, the triceps is the main muscle, and the sensation is over the inverted triangular region in the palm, and the triceps jerk is the reflex. And the wrist flexors are also coming under C7. C8 is the hand grip, the introduction, and the flexors of the motor flexors. So hand grip is represented by C8, and the sensation is at the inner aspect of the forearm. T1 are the interosseous muscles, the abduction and adduction of the fingers, and T1 sensation is represented in the inner aspect of the arm. So how to remember these root values? So this is what I used to during the PG period, how to remember it. The C5 is abduction, C6 is elbow flexion and wrist extension, C7 is the extension of the elbow and wrist flexion, hand grip is C8, and finger is T1, adduction abduction. Now, Now the dermatomes. This is one again, one another question which is asked in the the examinations on mapping the dermatomes. Normally, our postgraduates are exposed to the entire body with all the markings, which looks very complicated. Just have a look at the upper limb alone. You can see it's quite easy, I should say. You'll be able to easily remember it. The C5 is located over the outer aspect of the forearm, arm, and T1 is over the inner aspect. You can see that. And then you put the inverted V-shaped area, that's C7. So then we are left to the C6 and the T1. That's it. So it's quite easy there. So you can easily go through all these dermatomes, and then you can see the T1 is here and T4 is a nipple, T10 is the umbilicus level. So we'll go further, see that in the lower limb now. Now you should always look for human lesions in lesions of the cervical spine. The upper and the lower extremities, we will present with hyperreflexia and ankle clonus. And the two important findings which has to be looked for is the Hoffman sign. This is Hoffman's sign. So you flick the tip of the middle finger and you will see that the index finger flexes towards the thumb. So this is a very good finding which indicates an UMN lesion, very common in the cervical myelopathies. And the second one is the inverted radial or supinated reflex. You can see the flexion, the fingers goes into flexion when you tap it over the radial sternum. So this is the inverted radial reflex. And then the ankle clonus. This is a rhythmic repetitive contraction of the ankle plantar flexus after the ankle is rapidly dorsiflexed and held in this position. And this is quantified by counting the number of beats of clonus. You can see there. And you try to gently do it. Yeah. So he is just stretching the plantar flexus. And this is quantified by the counting the number of beats of the clonus, and a sustained clonus indicative of a severe condition. Now, the other findings are the Babinski's test. I'm not going to go into that. The open aim sign, like stroking the subcutaneous border of the tibia, you'll see that the big toe extends, and the finger escape sign. So this is a finger escape sign there, which is also again indication of a cervical myelopathy. There are other conditions also which can present with the same thing, but one of the features of cervical myelopathy is the finger escape. So you can see there, the little finger, due to the overaction of the extradigiti minimi, it goes into abduction. Yeah, that is a feature of cervical myelopathies. And the rapid grip and release test, you are supposed to
about the release test.
Yeah, grip and release it at least 20 times per second, 10 seconds. And this becomes slower in conditions where, in conditions of myelopathy, cervical myelopathy. There are special maneuvers which can bring out the various findings in cervical disorders. The Sperling sign, which brings out the nerve root irritation or compression. This is done by extending the cervical spine and bending towards the side of the presentation, and you will see that the symptoms are brought about with this maneuver. And this is a modified cervical compression test. And this is the cervical compression, like the diagram is self-explanatory. You just give a axial compression and also give a cervical distraction by which the symptoms are relieved. And the Lermit sign is a feature of cervical myelopathy again. This is an electrical shock sensation which occurs with the neck flexion and often radiates down the spine. In some cases, the sensation goes to the extremities, and it is probably caused by the hyperexcitability of the nerves, which becomes demyelinated. The other special maneuvers are the shoulder abduction relief sign, or the Davidson sign. Here, the patient, because of the severe pain due to the root tension, places his hand on the head and has a good relief of symptoms. This is the Dixon sign. And this is also an opportunity to rule out a shoulder pathology by this, if they're going to abduct it, because most of the time, the shoulder pathology also, in the aged individual, shoulder pathology also presents along with the cervical spine pathologies. And then you got to do the Adson's test to rule out the thoracic inlet syndrome, and also rule out peripheral nerve entrapment. I'm not going to details about each one of them for want of time. So that is with the cervical spine examination. Next is the thoracic and the lumbar spine. You should start with the inspection in the standing position, where you can see the spinal sagittal alignment. Looking from the side, you can see the sagittal alignment. You can have a sway back. Normally, it has to be like this. the head, the shoulders, the hip, and the foot should be in single line. This is a sway back, which may be due to like obesity or various other conditions where there's the retroversion of the pelvis, and as a result, there's increase in the lordosis and increase the kyphosis of the thoracic region. Or it can be a lumbar, increased lumbar lordosis, as in case of high-grade spondylolisthesis, or thoracic kyphosis as Schober's disease, or forward head thrust, which may be a feature of ankylosing spondylitis. So all these things has to be looked for, and you should determine the spinal balance. The head should be directly aligned over the sacrum, and any deviation from the midline may reflect a spinal deformity. So you can draw the line here, the plumb line from C7, and then the level of shoulders also has to be determined. As you can see here, the shoulder is lower down here. And you can have the plumb bob. This is a apparatus which the Masons use. The plumb bob, you can just hold it there over the C7 vertebrae, and you see whether they are passing through the natal cleft. So any deviation of this line from the natal cleft, like if it's going to be more than 2 centimeters, they are a sign of underlying neural disease or a spinal problem. Continuing with the inspection posteriorly, you got to determine the position of the head, the level of the hairline. So low hairline means probably congenital disorders, lack of the length of the neck, short neck is featured again of it. Congenital disorders of spine, cervical spine, level of the shoulders, level of the scapula, the deformity, whether you can see here there's a scoliosis here now, and then margin of the trunk. You can see in case of scoliosis, you'll see that unequal gaps between the arms and the trunk. And the spinous process, if they are prominent, the position of the iliac crest and the temple of Venus. So all these things you got to look for. And in subtle deformities of the thoracic spine with rotation, the Adams forward bending test will bring out the hump, which is present there. And this should be viewed from the bottom as well as from the head end. And in children, the forward bending test for small children can be done over the examiner's legs or over the parents' legs while keeping the child's feet on the floor, because they will be agitated. You got to do this on these children also to bring out the subtle deformities. And the scoliometer is one which measures the amount of degree of deformity. And the kyphosis, this is one other question which is asked in the examination, like what is a knuckle deformity, what is the angular gibbous, and what is a rounded gibbous. The knuckle is when a single vertebral body is involved, and angular is gibbous where 2 or 3 bodies involved, as in this case here. And this is a knuckle here. You can see just prominent spinous process there. And a rounded gibbous when there are more than 3 vertebrae involved, otherwise known as a global kyphosis, which is a feature of Schober's disease. Continuing with the observation, you got to look for the paraspinal muscles. If it's going to be asymmetrical spasm, it's seen on one side alone, it could be a disco-dural or disco-radicular problems. If it's going to be spasm on both sides, it could be a serious problems like metastasis or infection. Paraspinal muscle wasting can be a feature of chronic inflammatory diseases like ankylosing spondylitis, TB, poliomyelitis, myelopathy, and lower limb muscles can also be wasted in case of L5 investment root palsies and chronic hip pathology. So all these things has to be kept in mind. And they look for the neuroprotease markers like the hairy patch. You can see the hairy patch in the lumbosacral region, and the capsular spots, the midline lipoma. All these are indicative of an underlying spinal disorder like spina bifida, diastematomyelia, neurofibromatosis as the case of capsular spots or tethered spinal cord. So all these things has to be done in the inspection. Now coming to the palpation, you got to palpate all the bony elements, the paraspinal muscles, and the soft tissues. So sacroiliac joints will have to be examined. The sciatic notch, sometimes you can have a tenderness along the course of sciatic nerve. Hence the sciatic notch has to be, sometimes there may be tumors in the sciatic nerve which can present with the features of radiculopathy. And the abdominal musculature has to be examined. Abdominal organomegaly has to be done, and the examination not complete with the rectal and the pelvic examination. Now, the palpable step. This is one thing which we got to see. This is one another question which is asked the examiner is which spinous process is felt in based upon the type of spondylolisthesis. If it's going to be isthmic spondylolisthesis, you will see that the involved vertebral body moves forwards, leaving behind the spinous process there. And when you start palpating spinous process, you will feel that left behind spinous process in case of isthmic spondylolisthesis. Whereas in degenerative spondylolisthesis, the spinous process moves along with the vertebral body, which displays forwards, and the spinous process which is going to be most prominent is the one below that. So this is one question which is asked in examination. I think you should know this. Now, the movements of the lumbar spine, both the flexion and the extension and side bending has to be done. Any pathology in the anterior aspect of the vertebral body produces a restriction of the forward bending movements. Pathologies of the posterior elements produces restriction of movements in the restrict extension, and side bending restrictions can also be a part of facetal disorders. Now, next is the movement measures. See, if we saw the look, feel, move, and measure now. So what are the measurements as far as spinal disorders are concerned? So these are the various things you got to measure in your physical examination. They are the Schober's test, limb length measurements, costocrustal distance, which may be varying in spinal deformities, and high-grade spondylosis is grossly restricted. Sometimes the rib cage is sitting on the iliac crest. It can be like that also. And then you got to look for the thigh and the calf muscle measurements and look for wasting. And chest expansion is very, very important. Anything less than 5 centimeters, it could be ankylosing spondylitis. Now, in detail about the Schober's test, as you can see there, the initial one was the Schober's test, where the line at the level of the temple of Venus or the posterior iliac spine, the midpoint is determined, and then 10 centimeters above that, you mark a point on the axial spine, and then ask the patient to bend forwards, and it should be more than 15 centimeters. At 5 centimeters increase in the measurement has to be there if it's going to be a normal country, if it's going to be normal. But here, the movements were determined only in the lower lumbar levels. Hence, it is modified to include the L5S1 also, because the major movement is occurring at the L5S1 level. They modified the Schober's test, and we brought out the modified Schober's test, where another point is marked 5 centimeters below the line along the temple of Venus or the posterior suprailiac crest. And then this line here, 5 and 10 there, so 15 centimeters. And if they bend forwards, it has to increase by more than 5 centimeters. So 20 or 21 centimeters, it has to be there. So that is a normal one. So this is one question they'll ask you: how will you determine the segmental measurements? How will you determine segment mobility of the lumbar spine? You got to say the Schober's test. You should normally say modified Schober's test. They might ask you, what is Schober's test then? So you got to know all these things. Then scoliosis can occur secondary to leg limb discrepancy and is corrected by a block beneath the short extremity. And then all the more it's very important that you do a limb length measurement. Now coming to the thoracic spine. The thoracic spine does not have motor function. You cannot assess the clearly motor function, but you can assess by a partial sit-up where if there's a weakness on isolated one side, the umbilicus moves towards the contralateral direction. That is a Beaver's sign. I think it was knowing the Beaver's sign. And then the you should know the supply also. The cuff-flat portion of the abdomen wall is supplied by T5 to T10 roots, and the caudal portion by the T11 to the L1 roots. And these are the dermatomes also. You got the nipple level is T4, just about at the level and above the umbilicus, the T10, 11 and 12 below that. Now the abdomen reflex. This is one sensitive test which brings out the problem in the spinal cord, the thoracic cord.
Lightly draw the end of a pointed, but not
so you got to do it very gently, and the loss of the abdominal reflex indicative of a problem in the thoracic cord.
The pointed end of the patella hammer. Avoid scratching the patient's skin, as the abdomen is a tender area.
So that's how we do the abdominal reflex. Now the cremasteric reflex, this tests the integrity of the T12 efferent and L1 and 2 afferent neurologic levels. So here, the bilateral absence of this response is a feature of UMN lesion. Unilateral absence is the response of LMN at the L1 and L2 levels. Now, testing the L1, L2, and L3 levels, the motor is the iliopsoas. This is how we test the iliopsoas muscle there. And you should know, because in the examination, you'll be asked to demonstrate, and a lot of times you see that people are not able to demonstrate how they examine the iliopsoas. Each, the iliopsoas or the knee extensors, the knee flexors. So you should be also knowing all these things in detail. And these are dermatomes. I think I'll be going to dermatomes separately so that you'll be able to easily remember then how to remember the dermatomes. The neurologic examination considering the L2, L3, L4 roots, the quadriceps, and this is how you examine the quadriceps. The L4 level, you have the tibialis anterior, the knee jerk, and sensation is over this region here, the inner aspect of that. Like I'll go to the dermatome separately. The L5 level, it is the extensor hallucis longus. You got to examine the EHL weakness is there, and more important than that is the weak abductors, the gluteus medius, due to involvement of the L5 root. Because in fact, this will be presenting more than the weakness of the EHL. So this is the one which is going to present with the positive Trendelenburg's test. And you saw the if it's going to the Trendelenburg gait, which I showed you before this. The S1 neurological level, again the dorsiflexion of the ankle and the gluteus maximus, the extensors of the hip has to be tested. And this is how I remember it again. So I showed you the diagram for the upper limbs. So this is the root value here. You can just mark it like this, starting with the L2, 3, and 4, 5. Then 2 goes off. So L3, L4, and L5, S1. And then this is the L4. Next is L4, L5, and S1, S2. So the flexion is by, you just add L1 here. The flexors of the hip are L1, L2, and L3. The extensors are the L4 and 5. The extensors of the knee are the L2, just add 2 also. The L2, 3, 4. And the flexors are L5, S1. The dorsiflexor of the ankle is the L4, 5. And plantar flexor S1, S2. EHL is L5 and FHL is S1. So supposing there's involvement of L5. So L5 will affect the EHL. It will affect, even if you examine, there will be weakness of the flexors of the hip, and more importantly, hip abductors as well as the extensors also. Now the dermatomes here now. So this is, once you see it separately, it's quite easy here. So how do I say it is? The L1 region is a pocket area. If you have your hand in the pocket, that is the L1 is the pocket area. L2 is over the mid thigh and L3 is over the knee joint. L4 is over the inner aspect of the leg. L5 is the outer aspect of the leg coming to the middle aspect of the foot, dorsum of the foot. S1 is over the outer aspect of the dorsum of the foot. And then a narrow strip here along the posterior aspect here. You can see that. And then the S2, 3, 4 is here, the saddle area. S3, 4, 5, and 2 is also here. So this is quite easy to remember them also. So the neurological examination, S2, 3, and 4 roots, like this is the principal supply of the bladder, and it supplies the intrinsic muscles of the foot. So you can also look for foot deformities in these kind of cases. Perianal sensation may be there affected, which can present saddle anesthesia, and it mediates a superficial anal reflex also. There are special maneuvers which has to be done, which will be part of the physical examination lumbar spine. Most important being the nerve root tension signs. They are the straight leg raising test, the Lessig and the Bragard's test, the Bowstring test, and the contralateral or the well leg raising test there, which tests the L4, L5, and S1 roots. We'll go into each one of them. Coming to dynamics of the SLRT, the way you should express is like you should not say the SLRT is positive. Normally, you should say the degree where it is positive. Let's say, for example, if it's going to be painful at 60 degrees, you should say on the right-sided SLRT, 60 degrees painful. Left side, if it's going to be like 80 degrees painless, I would say 80 degrees painless. So I'm not saying 90 degrees because the reason I'll tell you now. So the 0 to 35 degrees, the slack in the sciatic arborization takes up during this range and there is no dural movement. So hence it is not very significant. 0 to 35 degrees is not significant. Whereas after 35 degrees, tension is applied to sciatic roots at this angle, and up to 70 degrees it is significant. And beyond 70 degrees, again, it is not significant because further deformation does not occur. And the pain, whatever pain you're going to see in the posterior aspect is due to the hamstring tightness. So most important thing is the significance is between the 30 to 70, 30, 35 to 70 degrees is very significant. And beyond that or below that, it may not be significant. So this is the Bragard test, the dorsiflexion of the foot. Like once you get a pain, you should decrease to 5 degrees and then try to dorsiflex it. There's a confusion, like they say Bragard's test is this one, or it's also known as Lessig's test. Like these are tests. Now the next one is the Bowstring test, which is the pressure on the lateral popliteal nerve or the popliteal nerve, thereby it's stretching the sciatic nerve by putting pressure on the these nerves in the popliteal fossa. All these are nerve root tension signs. Then the very important thing is the cross leg or the well leg straight leg raising test. Here, if you do an SLRT of the unaffected leg there, because of this relationship there, you can see there the relationship of the disc there. If you're going to lift the unaffected leg, it's going to go down, it's going to pull it, and this is transmitted to this region also and produces pain there. So that is the mechanism of the well leg or the cross leg raising test. And a very high incidence of sequestration or extrusion is seen at operations in patients with cross leg pain. Now the femoral stretch test or the reverse SLRT, they call it. This evaluates the L2, L3, and L4 roots. The disc is at a bit higher level. you got to look for the femoral stretch test, and this is how it is done.
Femoral nerve stretch test. Sorry about that. I'm going to pass it.
See how nicely they're holding it. Very important how you hold the limb also, and then perform the, and you got to stabilize the pelvis also there. See the other hand, they stabilize the pelvis, and then you got to do the femoral stretch like that. So this is the way you got to, because these are the ways you got to do it in an examination also. Okay, then coming to the, your spine examination will not be complete without assessment of the sacroiliac joint. So the first one is the, how do you test the intake, evaluate the sacroiliac joint? The all famous Faber test, mnemonic being the flexion, abduction, and extend rotation, and otherwise known as the Patrick test. And this is how you rock the SI joint on the same side there. And similarly, the Ganslin sign, this is how it is done. This is quite cumbersome and very painful also, not very popular. So you stabilize the normal side there and try to flex it here. And then rock the SI joint on the side where it is being flexed, the hip is being flexed. And this is quite painful also, not very popular.
At the edge of the table.
The other test being compression test and the distraction test. So put them on the side and try to compress it and distract the SI joints there by putting pressure over the anticipiliac spines there. And these are other two tests I showed you there previously. Now, before conclude, you should also, this is one finding which you got to be used when you're going to determine the level, especially in paraplegia or spinal compressions, where you got to determine the level of the lesion. So you got to correlate the spinal level and the vertebral segment. So you just remember this formula. The upper dorsal, you add 2 segments, plus 2 lower dorsal, 3 segments, up to 6, we can say 1 to 6, 6 and below. D11 vertebrae corresponds to the L3 and L4 segments. D12 corresponds to the L5 segment, and L1 to the sacral and the coccyx segments. So this might be useful. Like for example, if it's going to be a D4 level, means you got to just add 2. So the spinal level would be a D6, like that. So you got to determine the level also, because you are in your person, you got to say the reflex level, the sensory level, the vertebral level, and the autonomic level. So all these things you got to say, and then this is very useful in determining the level there. So finally, your examination is not complete without examination of the hips, pelvic girdle, and the vascular system. Say for example, sometimes the patient may have a very severe spondylolisthesis, and in the presence of one case I've seen that there was an arthritis of the hip also. And arthritic hip was more symptomatic than the spine problem. Hence, you got to attend to the hip problem first, and then come to the back problem. So hence that's the reason why you got to examine the hips, the pelvic girdle, and also very important thing is the vascular system. All these presentation, the pain radiating to the lower limbs can be due to the vascular disorders, and hence the vascular system has to be examined. Always completed by finally you just feel the peripheral pulses, and then you got to conclude the examination. Thank you.
Thank you, sir.
Thank you, sir, for your presentation. It was an excellent thing. With actually, you have thrown a lot of clarity on the examination point of view by showing visual treats with videos actually. So in that aspect, it was a very good presentation, sir. And postgraduates, if they have got any doubts, they can ask in the chat box. They can send you can send your questions to the chat box so that I can forward it to Professor Nalli, Uvaraj. Okay, meantime, let me ask a few questions, sir. Am I audible?
Yeah.
Yes, sir. So, in history taking, whether we should mention it as history of weakness or history of inability to walk or history of difficulty in using lower limbs or upper limbs, which word will be more apt? Weakness, inability, difficulty.
The history has to be like what the patient conveys to you. If he says, I'm feeling a feeling of weakness, then you got to say it's weakness. He feels as a weakness. So that's what we say, like, but you cannot say, like, sometimes there are people who come and say, I have a disc problem. You should not say the history, he says that there's a disc problem. You can't say that. But otherwise, the symptoms, whatever they have, they might say that there's a feeling of weakness, a global weakness may be there. Or there may be like he's getting tired easily, like that. Whatever word, it should be the words of this patient. Whatever complaints comes in the words of the patient.
Okay. Suppose the patient is already catheterized, bladder is already catheterized, and patient may showing improvement in his neurological condition over a period of time before he has stayed in our clinic. So how to ask for bladder control in a patient already on catheter in case he is improving?
No, the common method, what you do is we try to clamp the catheter and ask for bladder sensation, whether he is able to have the feeling of filling. So that is how we try to make it out. We just try to clamp the catheter and then ask for whether they are able to feel the filling of the bladder. And then that is the sign of recovery of the bladder.
So if he is able to feel the filling of the bladder, that is bladder sensation is, if he is able to feel, then we can take it that bladder control is also parallelly improving. Okay, sir. Should history include symptoms regarding higher functions like speech, memory?
Yeah, I did
history
not know
taking.
that because for want of time only. Actually, you're supposed to have any neurologic examination should have the higher functions as well as the cranial nerves also. Normally, I say that postgraduates, like we're not going to remember that normally. It's very difficult remembering that we don't bother to remember it. But at least for the exam's sake, you should, I think I just skipped it here now. I think it's good that you reminded this. We should always start with the higher functions and then also the cranial nerves there. So at least till you finish your examination, you got to remember the cranial nerves. Just know what are the tests to be done, what are the cranial nerves numbers, and then the tests for each nerve, you got to remember them. Very important.
Sir, how far is the history taking, history regarding other system illness important, like cardiac ailments, respiratory problems, renal problems, all these things? Yeah,
see, I said no, like it is not only to attribute these conditions to the pain, the symptoms in the spine. It is also important to like rule out the other conditions which may be associated with them. Or lastly, suppose you are going to take it up a surgery, all these factors are also going to play a very important role. So hence you got definitely in your history explore into the various other disorders also, other system disorders also. Very important.
So just to mention, sir, one of my patients, 17 years old female, she presented with kyphoscoliosis, but history wise, there was actually she was operated for patent ductus arteriosus when she was 50 days old. And the mother then confessed that she had only one kidney, that is absence of one kidney was there. And she had absence of this uterus also. So all these things came with the history only for me. So it was a kyphoscoliosis patient, 17 years old girl, and mother came out with all these histories. So I thought this is a valid question in history taking regarding this previous surgeries as well as the other system involvements. So one of the viewers has got a doubt. What is the significance of radiating pain greater than axial pain? I'm not able to catch the question.
Yeah. No, I can understand that. So, what he means by axial pain is the pain located to this, for example, it's going to be a low back pain just to the lumbosacral region, or whether it's radiating pain there. If it's going to be axial pain alone, it is indicative of some mechanical problem in the spine alone. And the presence of radiating pain is indicative of a radiculopathy. So you got to look for whether it's a radiculopathy. That's very important also, no? Whether that's got a distribution which will characterize that it is a radiculopathy. So any radiating pain is indicative of a root pathology. You should suspect a root problem.
So Dr. Prateep Patel wants to know, kindly explain the inverted radial reflex, sir, which I already mentioned actually.
Yeah.
Inverted radial reflex he wants to.
This is a feature of the cervical myelopathy, one of the signs of the cervical myelopathy, where you strike the radial styloid and you'll see that the fingers go into flexion. Both thumb as well as the fingers, they go into flexion. And this is a very sensitive test for UMN lesions due to cervical pathology.
There is one more question, sir. How to fix the anatomic level when there is difference in motor and sensory level? So
what I would say, like sometimes you come across that. I would give more importance to the sensory level. I normally consider that sensory level is more sensitive than the motor level. You cannot definitely say the level with the whatever available tests you have, but the sensory level is very, very sensitive. So I think better to put the level based upon the sensory level. And because even the recovery can also be very well made out with the sensory levels.
So you mean to say that sensory is the topmost priority?
Yeah, more sensory.
Level. Okay, sir. So more questions are expected from PGs. Meantime, I'll ask one question, sir. Regarding this Adams test, some people have got some view and some people have got different view. But you have rightly pointed out that Adams test is done to reveal the rib hump actually. Yeah. So on which side the rib hump is? People
your scoliosis associated with the rotation of the vertebrae. So that is.
So the purpose of Adams test is just to reveal the rib hump, and indirectly we take into account that it is a structural scoliosis.
Yeah, exactly.
Is it correct, sir?
Yeah.
So some people have got the habit of saying to differentiate between.
Yeah, the mild deformities you will not be able to make it out. So best thing is do Adams test and bring out the subtle deformities. So that is one more purpose why you use Adams test.
Okay. And regarding the general examination, sir, we actually skipped the part in presentation. What are the salient features which you have to look for in general examination?
I think one another thing is for want of time only, because if I'm going to start with that also, the number of things you got to look for. General examination, like for example, the features of ligament laxity, and then the other features like the other system disorders, the findings based upon that also has to be taken into consideration. Like as I said, on history, you got to explore the other systems also, so that the findings pertaining to that also has to be brought into it. And it is a very vast thing. That's the reason why I skipped it. I think you got to examine the patient as a whole, look at what are the findings there and come out with the general findings. And in examination for that matter, don't always go in for negative findings. Don't say, like for example, there's a clubbing of fingers. He does not have clubbing of fingers. He's got the intercostal muscles are wasted. The intercostal muscles are functioning. He's breathless. Like that, you should not give negative findings also. Any positive finding, like for example, there's a ligament laxity that you can mention there. So these are the positive findings alone you can mention in the part as part of the spine examination. Don't go in detail also.
Sir, which type of examination would be better for spine, whether it's standing position or sitting position or lying down position?
See, there is nothing which is important. If the patient, based upon the patient's condition, suppose he's got a severe neurological deficit, then I think no way you can make the patient stand and walk and examine. But otherwise, you got to see all. It has to be standing. Then you got to examine sitting also, and then also lying down. So various findings can be well brought out in these various positions. So you cannot do evaluate the sacroiliac joints by standing. There are tests also in standing also you can do it, but better brought out by the supine position. So there's no particular dictum that this is the best method to examine. It's not like that.
Okay, sir. Thanapan sir has got a question: how to clinically differentiate between a shoulder disc and an axillary disc?
Yeah. This will depend upon the presence of sciatic scoliosis. If it's going to be in the depends upon the type of list, which side the listing occurs. Like for example, if it's going to be the shoulder, the listing will be opposite to that of the symptomatic side. Okay, and if it is going to be the shoulder, it will be toward the side of the presentation. So basically, what is happening is the root is moved away from the disc. So if it's going to be shoulder, only by moving to the opposite side, the root will be moved away from the disc. If it's going to be in the shoulder, then the axilla, you got to move it on the same side so that it moves away from the disc, the root. That's it.
Okay, sir. There is one question from Dr. Bhaskaran. How to grade power in a spastic presentation of suppose TB paraplegia? How to grade power in a spastic presentation?
Same as MRC grading only, no? I really don't think it's going to vary.
So when the muscles are spastic, can we test for muscle power? That is what he's asking.
No, you will be able to do that. You'll be able to grade it.
Okay. And Suresh Sher has got a doubt. Can you explain the myofascial nodule or myofascial syndrome?
See, that has got a lot of explanations. There is no lot of theories like how it occurs, and also the importance of the myofascial syndrome by itself. some believe in the presence of a lump of fibrofacial syndrome. They normally say it's due to irritation of the particular root. No, like it leads to a presentation in the fibrofacial region with one of the painful spots. And sometimes we see that on occasions where there's severe pain there, we've been treating with all types of physiotherapy, bed rest, and medications. The patient does not get relief at all. And in some instances, I've seen, I just feel the painful spot there and just do an infiltration with the steroid and local anesthesia. They get a good relief. Immediately they have a relief. But the lot of people, like a lot of theories are there on the reason why you develop these conditions.
And many of the general practitioners have got the habit of injecting local anesthesia into the painful muscles and clear the pain from the patient. So this is happening in a lot of places. But you said it's diagnostic value, but they are doing it as a therapeutic.
That is not advisable. No? They will do any sort of things they do. Yeah. That's not advisable.
Yes, yes, sir. And Thanappan sir wants to know how to differentiate pain in history between mechanical and neurological, for example. How to differentiate pain in history itself,
like
mechanical and neurological.
Yeah, mechanical pain is brought about by particular movements, like particular postures or particular movements, and then it relieved by taking rest. Whereas suppose in neural pain, what do you mean by pain due to the involvement of the roots? And this can be brought about by increasing intrathecal pressure, like various maneuvers which increase the intrathecal pressure, and that brings out the neurogenic pain in spine disorder.
Can we say that mechanical pain is limited to the lower back and neurological pain is radiating pain?
Yeah, that's also, of course, if it's going to be involvement in the root, there's radiation of pain. And as I told you, like if it's going to be just pertaining to the axilla alone, then it's a mechanical pain.
And what category does this sciatic scoliosis come under? So it's a functional scoliosis or a structural scoliosis? Sciatic scoliosis.
It's a functional one. Once the disorder, you treat it, it becomes all right. It's not a structural scoliosis.
So what about the scoliosis arising out of short limbs? How to find out that it is arising out of short limbs?
I think I showed you in the examination itself. No, always keep in mind, you got to, in the measurements, one of the thing is the limb length. You should definitely do that. We should roll out that problem.
So you showed that keeping blocks under the feet also, we can correct the scoliosis.
Correct scoliosis.
So as a simple measure, if we don't have blocks, appropriate blocks, can we make the patient to sit on a stool?
That is one of the examinations suggested. If you feel that it is there, you just do a limb measurement and then come out to the finding. That's it.
Can we make the patient sit on a stool and the scoliosis disappears?
It can be. It can also become all right. The scoliosis disappears.
Okay. So there is one question from Dr. Rupesh. What are the common spine cases kept in the examination? Long case, short case. Long case, short case.
Very commonly, the ones which we get commonly is the disc problem. One is the disc, lumbar disc will be kept there. I don't think you'll get a cervical myelopathy. Mostly, you'll not get a cervical myelopathy. It would be either the lumbar disc or it could be a spondylolisthesis with a typical step and all there. And these are two things which will be commonly kept for you.
What about
the third one would be a healed tuberculosis. They're not going to give a fresh case there. I won't say healed one, probably it has been treated with presenting with all the neurological symptoms there. Patient has been on treatment or neglect treatment and then not much of pain there. Such case can be kept there. And rarely they can keep a scoliosis. Rarely they can. Very rare, I tell you. See, we ask the examiners and we'll try to avoid these very complicated cases.
But some examiners who are interested in spine like you, sir, who are specialized in spine, will at least they want one case for challenging case to discuss with the PGs. So in that case, is it possible that a scoliosis will come there?
Cases are for the spine fellows, not for the postgraduates. No? General postgraduates. No, we normally don't do that. We normally ask for, even supposing I'm interested, I want to have a spine. I will ask for a disc or a spondylolisthesis or a tuberculosis case. So that with findings also. Without a findings, there's no point in keeping examination.
There is a question from Dr. Tanigai Selvan. He wants to know whether L4, L5 disc prolapse, which nerve root will be compressed? in a L4, L5 disc prolapse, which nerve root will be compressed and why?
I think for that we should show the anatomy, no? So it depends upon the commonly it is the L5 root which is involved, L4-5. So because if you see the anatomy, at the L4-5 level, the L4 root immediately leaves out underneath the pedicle. And the traversing root is the L5. So that is what is commonly affected. So in very rare instances when there is a sacroiliac disc which is migrating up, it can also involve the L4 root also. So it is L4-5, it is L5 root which is involved.
What about cervical level, sir? What about cervical level?
No, even if it's going to be, supposing it's going to be a larger disc, if it's going to be a larger disc, then it can also involve the S1 and also the S2 there. Commonly it is L5, but if it's a larger disc, it can also, the next adjacent root also can be involved. Cervical level, it is one level higher up. No, supposing it is a C6 vertebrae, C6-7 means the C6 vertebrae, the root is above the C6 vertebrae. So it is only C7 is affected there at that level.
Again the same thing. C6, C7 is affected. Yeah. C7 nerve root is affected.
Exactly.
Okay. So what about this Klippel field syndrome, sir? Whether it will be placed in the, given for exam?
No.
Given it is a short case or?
Klippel field can be kept as a spotter. You can have short case also. You can keep it as short case. Very rarely, I'll tell you. Very rarely. I will not prefer to have that because there are lots of short cases. Why should you keep that in the examination? This is maybe a short case for the spine fellow. We can keep it, not for the MS or.
Okay. So as usual, you used to commonly say we should not use the term paraparesis. Is it still true that we should not use the term paraparesis? Instead, we should use the term incomplete paraplegia and complete paraplegia.
True. Yeah, exactly.
So there is no scientific word called paraparesis.
Yeah, exactly.
Okay. And suppose in an exam, a spine case is given with the neurological deficit. For example, TB spondylitis is given in an exam, and how to frame the diagnosis? How to frame that? So how should the diagnosis come from the mouth of the PG?
You mean that?
For example, yes, so for example, the patient is having a spastic type of involvement and muscle involvement, and he has sensory involvement, bladder involvement, and he has typically he has a motor level and a sensory level. And history-wise and clinical examination-wise, we find that the patient is suffering from some infective problem. So how to frame a diagnosis in a tuberculous spondylitis with neurological deficit and bladder involvement and bed sore?
See, you got to say, this is a case of tuberculous spondylitis. Okay, involving you can start with the vertebral level itself. Say, for example, it's involving the D4-D5 level with the sensory level, the motor level. It need not be the same level also. You can see that sometimes. So you got to say the sensory level, the motor level, the reflex level, and then the complications. Finally, you say with the presence of a pressure sore also.
So a diagnosis like this will it be correct, sir? The patient is suffering from a diagnosis. The patient is suffering from spastic paraplegia with vertebral level of D4 and motor level of D7 and sensory level of D8, probably due to a pathological problem like spondylitis, probably due to tuberculous infection with the complications of bowel and bladder involvement and a sacral pressure sore.
We need not say it's as a paraplegia or paraparesis. No, like I can say it's a case of compressive myelopathy.
Oh, okay. Compressive myelopathy.
Compressive myelopathy, probably due to tuberculous spondylitis of the D4-D5 level, with the following levels you can see, and the complications.
Okay. So anybody else has got any doubt? You can throw your questions in the chat box. I think we have discussed the common problems which the PG faces before the exam, and sometimes the PG realizes that we could have known the answer for this question after coming out of the examination hall also sometimes. So I think this session will provide him a lot of knowledge. He may not lose anything on a spine case if he is given one.
That's what I'm telling you. Don't as much as possible, try to see as many cases as possible, because we normally see only the hip cases only, and then we are very confident about it. So once you get a spine case, we are getting jittery. So like at least say, see 4 or 5 cases, you examine yourself and then present it, and then so that you will get the confidence in spine case also. It's quite easy actually. You need not worry about it. Okay, right.
Sir, one person is asking Dr. Thanige Selvan, how to elicit the bulbocavernous reflex? How important is that?
Yeah, this is for the incomplete lesions. I think this is very important test, whereby you can place your finger in the anal region, and then you got to pinch the glans penis, or you can also give a pull on the catheter which is placed there, and then feel for the anal contraction. This is an indication of incomplete lesion. Very important in finding out incomplete lesion. So
does it give any clue regarding recovery from spine?
Yeah, in spinal shock period, you may not be able to determine whether it's incomplete or complete. So this may be a very useful test.
So it will remind us about the recovery from spinal shock.
Yeah, you can expect a recovery also.
And at that point of time, is there any prognosis which we can give to the patients regarding the neurological recovery, motor, sensory?
Say that you can tell them, but don't give always, don't say like he's going to recover fully or something like that. You can say that there is a chance for recovery. Don't always give false hope to all the patients. Be
so
very guarded in your diagnosis as well as expressing the prognosis for any condition.
Okay. So at the end of history presentation is over, before going into the general examination and spine examination, once the history presentation is over, if the examiner is asking what is the probable diagnosis, then how to start? That is one question.
See, that's what I tell you, like at the end of the history, I said, like after the end of the history taking, you should be able to come to some diagnosis. If it could be a diagnosis, single diagnosis, or it could be a differential diagnosis. So I think in the examination, sometimes examiners might ask you, what is your different diagnosis? What do you think is a diagnosis here? I think you should be able to, by the end of the history taking, you should be able to come out with the differential diagnosis or diagnosis. It's very important.
And there is one question from Dr. V.R. Silva from TVMC. Can tuberculous spondylodiscitis present with listhesis? Whether it could be acute or chronic presentation, sir. He's combining two diagnoses now.
Yeah, no.
Whether can tuberculous spondylodiscitis present with listhesis?
Yeah. You have seen, like the various, because of the amount of destruction, gross destructions, you can see displacement both anteroposterior as well as in the coronal directions. The lateral listhesis can be there, or can also forward displacement. Even with tuberculous spondylitis, you can get listhesis also, due to the severe destructive lesions.
Okay. Any other questions from the postgraduates?
Is this the right time for the postgraduates to attend the classes? You should ask them, no? Are they finishing the duties and they are relaxed?
Actually, in most of the institutions, ortho-PGs are also involved in COVID duties. So, but
that is the reason why we are organizing it at this time, no?
But the thing is, they can view the same thing with the mobile phone also.
Yeah.
Presentations so they can see.
And also, it's going to be there in the YouTube, no? Like anytime they can have it.
Anytime they can see. So, if there are no questions, I would like to thank Professor Nalli Uvaraj, sir. What is this? Dr. Dharma Kumaran has got a question now. What is the common presentation of retrolisthesis?
Yeah.
Common presentation, retrolisthesis.
Retrolisthesis actually, it is more of a radiological diagnosis in cases of degenerative spine. So it may be an indication of the involvement of the facet joints with the advanced degeneration of the facet joints. They can present with the retrolisthesis, and most often they are made out on the radiology. And of course, the presentation is going to be the same as the other features of the spinal degeneration. It can be presenting with radiculopathy, or it could be just a mechanical pain.
So, which radiological sign is more specific for tuberculous spine? Question from Dr. Tyagarajan.
I think this can be
Which
answered.
radiological sign is more specific for tuberculous spine?
Normally, if this question is asked, I can say only if it's going to paradiscal lesion, suspect more of a tuberculous spine. That's it. And otherwise, it can be various radiology features in present, but anything which is going to paradiscal, suspect tuberculosis. Anything with the presence of
by paradiscal, you mean reduction in the disc height or what, sir?
Disc height, yeah.
Lesion?
It can be disc height reduction, or it could be paradiscal lesions in the vertebral end plates, or it could be a soft tissue shadow like the presence with the presence of a cold abscess. So all these can be indicative of a tuberculous spondylitis.
So we should not only look for the bone pathology, but also the soft tissue appearance. Also, we have to look for. For example, a bird nest appearance, or abscess tracking down the lumbar vertebra anteriorly or posteriorly. We have to look for soft tissue lesions also in tuberculosis. There is another question from Dr. Adit, sir. Does the CS of interpretation have any abnormal change in any spine pathology or degeneration, sir? That means he's asking about CS of
analysis. Is it analysis or
CS of analysis? I think he is talking about CS of analysis.
Yeah, CS of analysis, like as far as I can correlate this with the spinal tumor syndrome. They say, any obstruction in the spinal canal, the neural canal, can have some useful information from STS of analysis. Otherwise, not much actually.
Arachnoiditis, maybe that can be discovered. In a patient with tuberculosis who has a spinal tumor syndrome, maybe he may have arachnoiditis, and that may come out by cell count of the CS of fluid aspect. Okay. So I think we are already around 10 o'clock night. And with this, I think we can close the session. I would like to thank Professor Nalli Uvaraj for bringing out the clinical examination of spine with utmost clarity. And also, I would like to thank the candidates who have participated in this session and have asked a lot of questions regarding this clinical examination of spine. I would like also to thank Alembic Ramesh and his team, who have organized this program for the benefit of postgraduate students who are going to appear for the examination. I would also like to thank the TNOA President, Secretary, and also the other office bearers who have coordinated well with the company people as well as the postgraduate students, and come out with a proper format of topics and their presentation by selecting appropriate speakers also. So I'd like to thank everyone for this particular session, and any message from TNOA office bearers, the President and Secretary, please go ahead. I'd like to sign off with this. Thank you.
Professor Donopan? Donopan, sir? Donopan, you can unmute. Donopan? Yeah.
Yes.
Yeah, please go ahead with the closing remarks. Donopan, you have to unmute. You are in the mute. Yeah. Now, yes. Yes, you are now audible.
Okay, sir. Thank you so much, sir. Professor Nalli Uvaraj, sir. Thank you so much.
Yeah, thank you, Donopan.
Everything, sir. It's a very good presentation. I think a postgraduate will be benefited from this. And I thank Ramprasath also. And just one announcement, we are going to start another session by this Tuesday in short case format. So the program will be updated soon in the WhatsApp group. And I thank the President and the Secretary of TNOA as well as my coordinators and the advisors for this wonderful opportunity and this wonderful program. Thank you all.
Yeah, thank you everyone. Thank you.
Thank you, sir. Thank you, Alembic also. Thank you.
Thank you, sir.
Thank you.
Ramesh sir, end பண்ணிக்கலாம் சார் மீட்டிங்.
எஸ் சார். நீங்க சரி, ஓகே, நம்ம இங்க எண்ட் பண்ணிடலாம் சார். நீங்களே எண்ட் கொடுத்துருங்க சார். நீங்க தானே ஹோஸ்ட் இல்லையா?
கோ ஹோஸ்ட் சார். ஹோஸ்ட் தான் எண்ட் பண்ண முடியும்.